Very good morning. I think we'll go on to the cataract surgery symposium in children. One of my favorite topics. Of course, it has to be my favorite. I am a pediatric ophthalmologist. So I invite Dr. Sujata Guha ma'am, Dr. Rajesh Prabhu, Dr. Ramesh, and Dr. Sumita ma'am, and Dr. Ramakrishnan sir to be ready with their presentations. And I invite SG ma'am and Ramesh sir in the dais. So the first topic by Dr. Ramakrishnan, he is going to tell us how to evaluate children with cataract, when and what to do.
Good morning, dear friends. I would like to thank the TNOA and TRICON organizers for providing me with this opportunity. To start with some epidemiological perspective, almost 200,000 children worldwide are blind from pediatric cataract. It accounts for almost 20% of childhood blindness. And every year around 20,000 to 40,000 new cases are added. In India, almost 10% of childhood blindness are due to pediatric cataracts, untreated. The term pediatric cataract encompasses a wide range of childhood lenticular opacities, and depending upon the time of onset, it can be called congenital or infantile or developmental. If it presents within the first year of life, it is generally termed congenital, and if it presents later, it can be developmental. The etiology is very diverse. It ranges from idiopathic to being associated with various systemic syndromes. It can be unilateral or bilateral, and a majority of the unilateral and some of the bilateral are idiopathic. Some of the common causes include intrauterine infections like torch, and drug-induced cataracts are not uncommon as well, especially when children are treated long-term with steroids, especially in allergic conjunctivitis cases. And pediatric cataracts can be associated with metabolic disorders and inborn errors of metabolism. Any trauma in the form of mechanical or radiation or even laser can cause pediatric cataracts. Some of the ocular diseases like disorders like microphthalmos, microcornea, aniridia, PHPV and coloboma can also be associated with pediatric cataracts. Cataracts can be inherited either with or without systemic associations. Majority of the cataracts inherited without systemic abnormalities or autosomal dominant, and some of the families with high degree of consanguinities can be associated with autosomal recessive inheritance as well. And cataracts can be associated with systemic abnormalities like chromosomal abnormalities, including Down's trisomy 13, 18. And some of the syndromes like Weil-Marchesani can present with microspherophakia and ectopia lentis. You need to see the child as a whole, especially when they present with bilateral cataracts, because some of the syndromes with syndactyly, polydactyly, or CNS abnormalities or even cardiac disease can present with cataracts. Bilateral cataracts, some of them are idiopathic, as I mentioned earlier, and most of them are caused by intrauterine infection like torch, or some genetic disorders or inborn errors of metabolism can present with bilateral cataracts. White reflex or asymmetric red reflex seen in photographs are the most common presenting symptoms, and children with visually significant unilateral cataract may develop strabismus. Nystagmus may develop if bilateral cataracts starts early, and parents may also notice delayed visual milestones. A detailed history is mandatory, which should include details of the pre- and postnatal period, and family history should also be taken in detail. Slit lamp examination of the family members may give a clue towards inherited etiology if maybe some of the members might have had milder degrees of lamellar cataract which might have gone unnoticed, especially if it doesn't affect the visual acuity. A complete general examination by a pediatrician should be done in all cases to rule out any associated systemic abnormalities, and it also helps in assessing the fitness of a child if surgery is planned to undergo under general anesthesia. Visual acuity, whenever possible, should be measured in detail. It gives an idea about whenever we plan for surgeries and the timing of the surgeries. There are various charts available depending upon the age of the child, Bruckner's test and resistance occlusion may give a clue. Bruckner's test may give asymmetric red reflex may give a clue about the presence of milder lamellar cataracts. Slit lamp examination should be done whenever it is possible, because some of the lamellar cataracts, milder degrees, can be noticed by slit lamp. It can be missed when we see under indirect ophthalmoscopy directly. And indirect ophthalmoscopy and thorough fundus examination is mandatory in all cases to check the anatomy of the retina, and it also helps to rule out any other associated retinal abnormalities like PHPV or even retinoblastoma. Presence of squint or nystagmus implies poor visual prognosis. In a healthy child with no other systemic abnormality and unilateral cataract, you don't have to do an elaborate laboratory investigation. Nevertheless, thorough ophthalmic examination should be done to understand the anatomical aspect of the cataract, which will help in planning the surgery. Some of the bilateral cataracts might be idiopathic, but bilateral cataracts should be thoroughly evaluated for any systemic associations. Slit lamp examination, as I mentioned earlier, slit lamp examination of family members might give a clue about the inherited etiology. Routine lab investigation should include a complete hemogram and blood sugar levels, and other tests may be ordered on case-to-case basis depending upon the suspected etiology. It is always a good practice to have a referral team, including a pediatrician, pediatric endocrinologist, and a neurologist, to arrive towards a diagnosis. Whenever there is any difficulty in visualizing the fundus, it's always a good practice to do a B scan. Ultrasound B scan will give an idea about the condition of the retina, posterior segment. In addition, the B scan also provide useful information like axial length, which is useful in calculating the IOL power. And keratometry should be done whenever possible. A handheld keratometer is a very useful equipment, but whenever it is very difficult to assess sometimes in very young children, it is difficult to assess the keratometry. So we might go with approximate K values like 43 or 44. Pediatric cataract usually causes vision loss by many ways. Main aspect is vision deprivation, direct vision deprivation. It can lead to amblyopia, anisometropia, and dense cataracts can cause nystagmus, and unilateral cataracts can cause strabismus as well. Management of pediatric cataract is influenced by various factors like laterality, presence and density of amblyopia, morphology of the cataract, and the visual potential that can be attained after surgery. Any cataract that is central or posterior, which is more than 3 millimeter in diameter and reduces the vision 6/18 or less, which causes squint or nystagmus, is considered visually significant cataract. Treatment is mainly surgical, though there are some non-surgical aspects, modalities are also available, and it will be dealt with in detail by following speakers. Thank you.
Thank you. So the take home for students, if there is a bilateral cataract, you have to pay attention to systemic, any associations or genetic factors are there. And if it's a unilateral cataract, you mostly concentrate on eye, whether it's a microcornea or PHPV, or so that is broadly how you, how sir nicely mentioned.
I have a question for you. If it is a bilateral cataract and there is no family history, what are the baseline investigations you would advise for the initial purpose in a child? Say it is not a congenital cataract, but you would like to rule out inborn errors of metabolism. You can't order for such a big panel.
Tests, no.
Yeah. So what are the baseline?
The baseline test in all children, I would have a complete hemogram, and bilateral cataracts, I would definitely do a torch titer,
Right.
and systemic evaluation by a pediatrician, and probably if we suspect any, based on the morphology of the cataract, if we suspect any syndromes, probably we can go towards endocrinologist or any inborn errors of metabolism.
Okay.
Yeah.
Maybe we can do some reducing substance as a baseline. And if we have it positive, then you can investigate for G6PD. Or we can do
Galactokinase,
proteins
yeah.
in the urine as one of the
Urine
baseline.
is one. Yeah,
yes.
urine can be added. Yes. Thank you.
So now I invite Dr. Rajesh Prabhu to tell us about the controversies in IOLs in children, when and how and what IOLs we have to.
Thank you, Dr. Sriram, Supraja, and Dr. Swarna for this opportunity and warm hospitality. So my topic is like, I have to answer 3 questions in 8 minutes, like when, how, and what regarding IOL in children. I thought if I am able to answer the question of how and when and what parts forms a part of the answer. So how? There are a lot of points to be taken care. One is the timing of surgery, when to place IOL, preoperative evaluation already Dr. Ramakrishnan has dealt with, choosing the IOL power, choosing the section, surgical steps and complications, what IOL to place, and whether to do IOL before PPC or after PPC, and post-op management and rehabilitation. So when to operate? As a pediatric ophthalmologist, we'll be really tempted to operate very early in infancy whenever we see a congenital cataract, particularly with the advancement of your pediatric anesthesia care. As and when the child gets fitness, it is easy to operate. But as a lot of papers say that there's high risk of glaucoma when we operate very early in infancy. So we have a window period of around 6 to 8 weeks in case of bilateral cataracts, and a slightly lesser 4 to 6 weeks in case of unilateral cataract. And most of us will agree with this. The time interval between 2 surgeries is around 2 weeks. So when to put an IOL in children, and there is no doubt that more than 2 years of age, primary IOL implantation will be the option by most of the pediatric ophthalmologists. And less than 6 months of age, lensectomy with PPC with anterior vitrectomy followed by contact lens or glasses is the most preferred options. And I don't know how many of you are practicing contact lens in infants. It's really difficult in the Indian population. But what we see in long-term follow-up is many of the children, particularly with bilateral cataracts, very well do with aphakic glasses. We have a follow-up of around 15 years. And secondary IOL can be planned anytime after 2 years. And I personally prefer to wait till 6 to 8 years after the hematopization, probably slightly earlier, around 2 to 3 years in case of unilateral cataract. 6 months to 2 years is again a question of, a complete discretion of the surgeon. Many surgeons will prefer to put IOL after 1 year of age, again, depending on the type of cataract, your corneal size, diameter, and all other factors. In case if you are not able to put a lens, second IOL can be placed after 2 years. IOL power calculation is very important in children. Less than 2 years of age, we still follow this Dahan et al., though it is very old paper. We do a biometry if possible and undercorrect by 20%. And sometimes if we are not able to do biometry, we have a calculation based on the axial length. This is for less than 2 years of child. And between 2 to 8 years, do biometry and undercorrect by 10%. And above 8 years of age, we always try to keep the same power. Sometimes we might have to follow this NID et al.'s refractive goal rule of 7. So depending on the age, how much hypermetropia is expected, it's calculated based on this formula. And IOL formulae, there are no specific formulae designed exclusively for children, so it is very less accurate because of these factors like shallow anterior chamber depth, high K values, and short axial length. So in adults, the accuracy is within 0.5 diopters, but in children, the accuracy level is really difficult. There are various formulas in children to be used in pediatric IOL calculation, but I personally prefer SRK2 holds good for most of the cases. Choice of IOL, there is no doubt, and hydrophobic acrylic single piece or multiple lens in the bag fixation is the most preferred technique followed by most of the pediatric ophthalmologists. In case the patients are not affordable, PMMA is still a good alternative. Single piece or multi-piece, again, when it is placed in the bag, it doesn't make any big difference, but there are definite indications for 3-piece IOL, which I will be dealing it later. White versus yellow, again, I personally don't prefer yellow lenses, but still there are many lenses available with the yellow platform. Optic capture is not my choice, so generally I prefer to put in the bag, and still many surgeons do prefer optic capture with the 3-piece lens. Multifocal and toric is still emerging. There are various papers to show that a hydrophobic single-piece lens is the better lens in children. 3-piece, there are definite indications for that. Secondary IOL, whenever you plan, most of the time the anterior capsule and posterior capsule are fused and formed and fibrous. So you will not be able to open up the bag. It's very difficult. So at that stage, we might have to prefer for a 3-piece IOL. Traumatic cataract, yes, always have an option of 3-piece IOL in hand, because in case you might have to put it in sulcus, we end up in putting a 3-piece IOL. Optic capture, if you plan, definitely it is possible only with 3-piece, not possible with single-piece IOL. IOL exchange, which is very rarely done nowadays, if at all needed, it needs to be a 3-piece IOL. Anterior vitrectomy, everyone will agree that less than 8 years, it is a must for all pediatric cataracts. 8 to 12 years plus or minus, and about 2 years, 12 years, it might not be needed. Again, PPC, there are two ways of putting it, like before IOL implantation and after IOL implantation. Before IOL implantation, there has many advantages because of better visibility. But once you do a PPC and vitrectomy, eye becomes soft. Sometimes for beginners, it is very difficult to put the lens in the bag. It might hamper the IOL implantation in case if the PPC extends. And always aim for a small PPC, because once you put the lens and extend the bag, the PPC might become an adequate size. After IOL implantation needs little expertise and technique. But the problem is that poor visibility, because you have to, go under the IOL and do a PPC. But once the IOL is stable in the back, you can plan a little bit wider PPC in those cases. So here are two videos demonstrating the PPC before and IOL after IOL implantation. You can see either you can do a clear corneal incision in the first case, or you can do a scleral corneal tunnel. The cortex can be aspirated either with the phaco probe or with the Simcoe, whichever you are comfortable with. So initially the IOL is implanted in the back, secured very well, and then you can just, with the help of a spatula, just lift the IOL gently, go under the IOL, place a small nick. With the help of a Utrata forceps, just hold it and complete the PPC as like normally you do with the before putting the lens. And if you have a good microscope with a good red glow, things becomes very easier. Second case, it's very easy for beginners at least, because it's open sky method. So before the IOL implantation, you can just make a small nick and complete the PPC, and then you can do a gentle vitrectomy. So after PPC, you can just squeeze in the lens inside the bag. So this is a normal cataract. There are special situations where you might have to deal with subluxated lenses and no PC support. So we stopped doing CONE IOL in such cases. Our preferred choice is SF IOL and iris claw. I'll just demonstrate a few videos about SF IOL. Just take 2 more minutes for this video alone. So this is a technique which I follow. We make a 2 limbal incisions opposite to each other with a blade, and then create a small scleral pocket on either side. This is where the externalized haptic has to be tucked in. So the same thing is demonstrated here. I'll just skip this. After removing the lensectomy, so the second technique. After that, you have to enter on both sides of the scleral tunnel into the pars plana, and then you have to put a 3-piece lens inside, externalize the haptic, and both the haptics are tucked inside the scleral pocket which you have created. I use a pre-PMMA rigid lens oral lab. I don't have financial interest in that, but it's a very good lens for this technique. So once the haptics are externalized, gently pull the haptic and just tuck in the scleral pocket which you already created. I'm just skipping the video of iris claw. There are papers published in support of these iris claw lenses. We have one paper with Dr. J.K. Reddy from our hospital, and it shows a very good results. And regarding this SFIOL, we have our own publications. In 2017, we have done 15 eyes with oral up 3-piece lens, and we have a very good postoperative visual recovery with no major long-term complications. Thank you.
Just want to know your longest follow-up for SFIOL and iris claw.
2014 I started, madam. Now, right now, 9 years of follow-up. Iris claw I don't personally do. That's a video which has been shared one of your cornea surgeons. But I personally do a sutureless scleral fixated IOL, which I have 9 years follow-up.
So it remains centered, no issues about.
No issues, madam. We have one patient where the 3-piece lens dislodged, and we have to convert into iris claw lens. So far, others are doing good. No suture. Just tuck in, say, this scleral pocket and then leave it. It fibros and becomes
So
stabilized.
age, minimum
The
age,
youngest age which I operated was 5.5 years of age.
but
So
generally,
though I take 6+ as my preferred option, one patient I have to, took little risk and did at 5.5 years of age.
thank you.
Do you have any excellent criteria? So ophthalmic eye and all that. Do you
No.
avoid this
No, madam.
technique?
No.
Because they have a large diameter of the lens.
So that's why I prefer this ROLAB 3-piece lens, because it is 13.5 millimeter diameter, total diameter. The other lens, foldable lens, has got only 12.5. So that is the reason I prefer this lens.
Okay, thank you.
Thank you.
Dr. Rajesh. Now I invite Dr. Ramesh to tell us about intraoperative challenges, how to anticipate and how to manage.
Start from first level. I thank TNOA, local organizing committee, Dr. Supraja, to give me being part of this session. Surgery is always a complex mechanism in a congenital cataract. Like we all want to have an end result of something like a good anterior excess, posterior excess. A small video of how a normal surgery is performed. I am basically a pediatric ophthalmologist trained 30 years back when we never had an IOL at all, not even an adult case. So the key points I like to highlight in here is like I'm just showing a nice normal case wherein here you can use your lamellar zone itself as a rexus marker. And one other tip I'll advise all the younger pediatric ophthalmologists is to be ambidextric. Start practicing using both your eyes for your right and left coordination so that you get a good rexus. And that's very essential and key to the success of ideal intraocular lens surgery. And I had the opportunity to learn certain steps of observation or some steps from Dr. Abhay Vasavada. So being a high volume adult cataract surgeon, I think things were better, but then still in the initial days, I still remember not even doing a posterior rexus, just implanting lenses and then using a vitrectomy cutter to just do a posterior capsulectomy, not even a rexus, but it comes with practice. So every step, few of them were presented by Rajesh, like nice implantation in the back is always a nice thing to see. Your surgery goes on so well, but that's not the case in situations as I'm going to show now. And I prefer suturing all my main port and side ports, especially in infants, for fear of endophthalmitis and other issues. And you need to have the ideal instruments. I leave the micro instruments, and whenever we make a incision, like when you go through cornea, you can see the dimple happening. Your visualization gets hindered. So either there should be overlocking or there shouldn't be any loose wounds. And always it's a ripping force you need to do when you do a capsular rexus, because your pull is towards the center of the pupil. That's when you have a good control over the then good viscoelastic gel, so that it just keeps your anterior segment nicely formed. And we still do have a runaway rexus once in a while, so we need to be prepared for it. With the micro rexus scissors, we need to trim the capsule, and then probably at this juncture, as Rajesh told, we need to have a 3-piece foldable lens in hand, so that you have only one radial tear and you're able to implant a 3-piece foldable lens. You can still safely go ahead and do it. But all this instrumentation is very essential. And many times we do face a absorbed cataract with a thick anterior capsular plaque. And this child, I still remember, I had a presentation in Copenhagen once in an ASCRS meet. It was just selected for one of the best video sessions. But this child was ignored because he had a small myotic pupil. So nystagmus, amblyopia, everything was there in this child, and fibrotic capsule. So it was not just your microrexis scissors alone was not sufficient. I need to use even a MER knife to cut this capsular plaque, anterior capsule. It was just literally a plastered anterior and posterior capsule. But somehow I remember this case took a lot of pains and time. I could put an implant IOL in the back with all this multiple entry points. Still it went on very well, and the child is now close to 12, 13 years of age, somewhere around 636, 624 vision in the better eye. If not, one eye was esotropic and amblyopia. So when we do encounter this sort of situations, simpler way of managing is probably to do a lensectomy and leave it aphakic. Maybe later on, the rim of anterior rim, we can always go ahead and do a secondary IOL procedure. Many times we may think the lens is soft enough, but it's not so. So in that case, already you have a phaco probe. Just by aspiration mode, you can always engulf the whole set of your nucleus component. So it's not always that you can use only your IA probe and take your lens out in this sort of scenario. So most of my videos are always corneal approach because I am used to that. And posterior rexus, yes, like I always felt like it is not that your tactile feel, it is more of your visual sense you're really performing it, because you hardly have a feel of what you're doing it. So you need to have a good zooming on your microscope. I need to really give a nice rip, so that try to attempt it to keep it as small as possible, because we don't want to have a huge large one so that it compromise the. And here is one case where I was just able to even little bit do a spiraling of the posterior axis. Not that as easier, and see, once in a while this helps us even to when we actually when we start managing adult cases polar cataracts. The next speaker is going to be talking on this. We'll be able to handle when we handle adult PCRs, doing a small rexes. This all helps us in handling these children's eyes also better. So spiraling will give us a good control. Then bloat the bag with heel on, anterior of course, and bloat the bag with heel on, and then just have to implant the lens in the bag. This again is a plaque in the posterior capsule. Many times your regular instrumentation may not be sufficient. So whatever that really works on that scenario, the same case where the anterior rexus was done, you can see the anterior rexus is complete in spite of the thick plaque. The same is there on the posterior plaque. This is a one-eyed child, because the other eye was esotropic, amblyopia, nystagmus. So I was sort of try my best to not leave her aphakic for the fear of aphakic related issues, rehabilitating her, aphakic related complications. Luckily, it went on well. So the child has at least one eye, the good vision. So here, literally, it was the micro scissors was not cutting at all. So I had to use a MVR knife in all directions, and PC dehiscence is one again a commonest thing we will be encountering in few of our pediatric cataracts. The only key thing is, as we do in adult case also, whenever you keep the irrigation on and just remove the aspiration port and inject visco gel to form the chamber and then take the aspiration port. This is what we do in adult cataract also, for not to extend the PC run, so that either we can still do a good PC rexus in these cases, and now bloat the bag between the anterior and posterior leaflets either side, give the bag a nice shape before you go in for an IOL implantation. I've had few cases where the lens, the initial haptic tailing into the vitreous, then you need to retrack it. So nicely, safely implant the lens. In the case of a dehiscence also. I think it's just coming towards my completion. And we all know, like IOL implantation, especially when it's a fibrous bag or a capsule, then you are going to have a tough time. It's not as simple as we think. Sometimes the knuckle of the optic haptic junction doesn't really budge into the bag at all. You may have to keep on perseverantly trying it out, and you just have a crowded space. So there's going to be multiple maneuvers. It's an edited video. So sometimes I remember I struggle 20-30 minutes even just for an IOL implantation. Let me be very frank. So, but ultimately we need to, with a single piece lens, we have to place it in the bag. There is no compromise at all. If we're not able to do it, better don't do it, or at least put in a 3-piece lens, at least optic in the bag, and maybe the haptics can be in the sulcus and capture. And if it is a corneal wound, or even if it is a scleral wound, I think the main wound should be sutured. That's my advice, for fear of egress and endophthalmitis and related complications. So, and only thing is, like, you may have to take them to OR after a month or two, because the sutures are bound to get loose. I use only 10-0 nylon. It's a simple procedure. We can always take the sutures out. So it's about the surgical sort of nutshell. Thank you. Anything you have, can always ask me.
Yeah, very nice videos. As you rightly said, if you're planning to put a lens in the sulcus, always put a 3-piece, and that's very important for all the students. Never put a single piece in. By mistake, you have a problem where the lens is now going to be in the sulcus. You need to really take it out and put a 3-piece. Some other comments that I would like to make is that in case of mature cataracts, when you see an intumescent lens, try to aspirate rather than starting the rexus. Try and go and aspirate the contents of the initial part, so that the anterior capsule, which is convex, becomes concave, and then you can go ahead. Try to do a spiral rexis where you initially start small and then gradually increase because of the intumescence. Sometimes that can run to the periphery. And thirdly, when you already have a PPC and you want to put an intraocular lens, don't aim towards the posterior capsule. When you have an intact posterior capsule, you can easily push towards it. You don't have to worry. But when there's an opening and that's the area of least resistance, aim towards the anterior capsule or toward the equator so that when the lens opens, it doesn't nudge and fall inside the witches. Yeah, thank you.
And another point that I wanted to make was that if it is a fibrotic capsule, then instead of using forceps because it pulls on the zonules, we can use a cutter.
Yeah.
Cutter is a very safe and good instrument to take off fibrotic capsules of the.
Absolutely. Thank you.
So I would now call upon Dr. Kavita Kalaivani to discuss pediatric cataract in special situations.
Sir Ramesh, I have one question. With permission. Many people prefer to use a vicryl suture for closing the wounds. So what is your take on that?
At least I don't have an experience, but at least even for my adult traps, I use only 10-0 nylon. Only off late, I've been seeing my son Prasanna using a 10-0 vicryl for his flaps. So maybe I don't have an experience. Maybe anyone.
I use vicryl sutures for
Even
all
for
my
corneal
cases, or even the corneal wounds. But there is a but in it. If the vicryl suture is a little loose, it tends to collect mucoid material. So you will need to keep them on antibiotic cover throughout the length of time till the vicryl suture absorbs.
I have published a comparison between nylon and vicryl. It's there in the IJO where we have tried. The only difference is vicryl leaves a lot of white marks, so the amount of reaction is much more compared to nylon. But nylon suture, even at 3 years, can get loose and cause a lot of issues with upper tarsal, papillae and all that. So you have to be aware of the same thing.
Yes, vicryl causes scarring and it accumulates mucoid material. I have had a child who has had infiltrates because of the mucoid material deposited due to the vicryl strands. So, Dr. Kalaivani.
A very good morning, and I thank Dr. Supraja for this opportunity. So I'll be dealing with a lot of complex situations Dr. Ramesh was mentioning, but specifically 2-3 conditions. Pediatric cataracts are not always, we say laddu case. It's not always like that. So routine surgery is the main key things that we have to take care is the anterior rexis and the posterior rexis. Usually, once you have both, then you are quite comfortable, but that's not always the situation. So we have a lot of complex situations, the commonest being trauma, with all sorts of involvements, cornea, iris, everything can be involved and we have to manage everything. Uveitic cataract is again a specific entity, which is not just any cataract. And posterior polar cataracts are very common in children, and there are things which we have to look for and manage accordingly. So traumatic cataracts, I won't go into details. It is a very vast topic in itself. So we come across all sorts of situations when we have trauma and cataract with everything associated. It can present at any type of time, any age. So these are the things. So a few small things, like if it's a blunt trauma, penetrating trauma, a lot of things. So here this child, the iris was completely stretched and was attached to the limbal small scar, and we had to really create a post-pupillary axis by using a cutter and then find a huge total cataract, which was removed with a cutter because it was a 4 months baby. And this is another situation where it was a penetrating trauma. So we had time, you manage the corneal wound, let it heal, and then do a proper DBR and do an elective procedure where you can implant the IOL at the same sitting as the trauma if the child is older. So these are a few pre-post conditions where IOLs could be implanted, which is the happy ending most of the time, even in trauma. So protocols generally, when you have children with cataract and trauma, you manage the cataract later if the capsule is intact and all that. Never try to manage the cataract during the primary repair if cornea is open. And timing of cataract surgery, if you do not operate in the primary sitting, then 1 week to up to 1 month if the child is very young. In amblyogenic age group, it is crucial to clear visual axis and not jump into putting IOL. If you have to defer it, you can defer it, but clear the visual axis first. And presence of the wound, corneal wound, determines the IOL calculation and placement and timing, etc. Concurrent iris issues sometimes may have to be managed simultaneously, so you should be prepared with instrumentation and experience for this. and long-term follow-up. Once a trauma is there, it is like lifelong follow-up for glaucoma and retina issues. So the other entity is one of my favorites. It's uveitic cataract management in children. Uveitic cataract is very difficult even in adults, but in children it adds to more challenges. So due to the disease process, drugs, steroids, the child health itself is also a challenge. So you have to really wait so a lot of things to look before, during and after. So cataract comes during the course of the uveitis condition, and it's not in the beginning or in the end. So you have to have a very good systemic control of the disease, which the uveitic specialist will take care for us, luckily. And intraoperatively, the main things are the pupil, capsule, and the IOL. So the preoperative checklist should be disease activity. Disease should be completely quiescent for at least 3 months. And cataract is there or not. Sometimes it's very confusing. You can have a retrolenticular vitreous haze, which can mislead us and challenge us whether it is cataract or not. So you have to be very sure whether the surgery for cataract will help or not. And then clearance for surgery, good immunosuppressive cover, all that is extremely important. And as we say, pediatric uveitic cataract surgery management does not begin on table. It begins much earlier than that. So the surgery as such, major factors is pupil, capsule, and the lens. So synechia lysis, there is a first important step is to release the synechia. Most of the time we have a synechia, so which has to be released. Sometimes there is a layer of iris actually stuck to the capsule, after which only you can really approach the capsule and even stain after that. So you have to look for it and release it. And you put hooks. See, that kind of a layer can be there. And then capsule in uveitic cataracts are more difficult than a pediatric routine capsule. They are soft and friable and keeps running. So you have to stain, as in any pediatric cataract. You have to use a heavy viscoelastic like Healon GV, no financial interest, but to keep the anterior capsule flat. And a nick first you should do. If it is intumescent, release the pressure and then continue with the rhexis with the forceps. And posterior rhexis is very important, and many times anterior vitrectomy has to be done even in older children if it is uveitic cataract. And consider not doing, there is a controversy. If you can do YAG later, you can sometimes defer posterior rhexis if you feel you can induce traction or anything, but this is still a controversy because they form PP's capsular opacity much earlier than a regular child. So decisions to put IOL or not, again, depends on the type of uveitic cataract. So many times you may have to just remove the lens and manage the inflammation and treat the aphakia later. Especially in GAA in a very young child, IOL is still a contraindication. Otherwise, IOL is always in the bag. There is no role of IOL in the sulcus in a child with uveitis. So even this cataract, you can have a nice in the bag IOL. So surgery over, nothing is over still. The inflammation can still continue. So you have to keep monitoring for PCO, CME. Even if you do a PPC, the membrane keeps forming. So you may have to keep managing that. And steroid immunosuppressives continue as long as it takes. So the challenges needs really special attention, not just another cataract surgery in a child. Pupil and capsule management is extremely crucial, and parallelly we have the issue of amblyopia as pediatric ophthalmologist to take care. So the next entity is posterior polar cataracts, which is really very common than actually is probably stated. We suddenly get a surprise open PC. Sorry. So it's a short video, just want you to. So very common, small, maybe asymptomatic also. You can actually watch, observe them, correct them with refractive correction. Many times bilateral, there is always a pre-existing weak capsule. You have to anticipate even if there is no dehiscence. Central core is dense, that's a clue. And there is a ring-like opacity. Even in a very dense cataract, you can even make out that ring-like opacity, which is a clue that the PC may be dehiscent. So you can see in this child, there is a ring-like opacity. So you have to stain anterior capsule. Anterior capsule, you can make it a little smaller just in case PC is not really good and you may not have the bag. If you're planning an IOL, you can keep the anterior capsule a little smaller. So you can see the PC, that ring-like opacity that I was saying, which says that the PC may not be present. So yes, you really have lower settings. Remove the cortex and you notice that the cortex there is a very nice central round PPC, open PC. So this was a 7-month-old child, so I think IOL was not implanted. So a nice clean vitrectomy, and you did not have to do anything to the PC because it was already open. So capsulotomy you can do with a cutter also, cortical aspiration again with the cutter. If you're not planning an IOL implantation, you can use all these procedures just with a cutter. You don't need any other instrumentation, even for the anterior capsule, if you're planning only a lensectomy. And finally, if you're, so that, see again that posterior capsular ring, which shows that there is a dehiscence. It's a large dehiscence, so ideally not a single piece lens, so you have to use a 3-piece lens in the sulcus. Or you can, if it's a smaller end, you can use a 3-piece lens, attempt to insert it in the bag, but if you're not lucky enough, then you can at least insert the same lens in the sulcus. Never try a single piece lens in this kind of a PC. So a tips to tackle PPCs in children, you anticipate a weak or absent PC always. Dilatation is really must. You can put hooks if you need. Stain the anterior capsule and smaller anterior rexes, low settings. Aspiration using a cutter and 3-piece IOL standby. Thank you. So to summarize, pediatric cataract management can be complicated with other issues. So good pre-op assessment and anticipation and preparedness and good instrumentation goes hand in hand. Thank you.
Yeah. Dr. Kavita, very nice videos and very good tips. For uveitic cataract, I prefer to do peripheral iridectomies because over time, there is a formation of iris Bombay, and I have seen patients even about 2 months later having that blocked in spite of having that. So that can be one important thing that you can do.
Yeah, I agree, but routinely, because we do not do that routinely. If the inflammation is very
In
nicely under
fact,
control, because
one
many
might
times,
get blocked. I have had when situations where the entire 2-3 peripheral iridectomy got blocked, went into iris Bombay, went into high pressures. Very difficult to tackle
very
such
true.
situations.
Recently, we had to do only iridectomy after doing a cataract surgery later. So I agree that.
So normally we don't do, but initially I was not doing, and then I started getting these issues. So now it's become my routine to do peripheral iris. I do 2, and I see them getting blocked. As she rightly said, those also get blocked. And
Very true.
And
That's
in
an
fact,
important point. Yes.
Yes, and certain types of uveitis, in spite of doing a PPC, you can find reaction behind it.
Yes,
So
yes,
you
yes.
go
You may
ahead
have
and
to
do
add that,
Yeah,
actually,
that's-
yeah.
The other important thing, like just like posterior polar, one thing which we as pediatric ophthalmologists and students should know is posterior lenticonus. So many a times, if you have a unilateral cataract, it may just look like a normal, but when you start operating, you'll see the small ring which you mentioned of that particular flimsy posterior capsule which is there, and those areas you'll see these dots beyond it. Can also give us an idea that there is a component of posterior lenticonus in especially cases which are otherwise normal unilateral cataract and no other systemic issues.
True. So you have to watch when there is a unilateral cataract. Thank you.
I would now call upon Dr. Sumita Agarkar to talk about complications of pediatric cataract surgery.
Lens
Good
in the
morning.
back. What is there a real need? Rajesh is telling about why not practice PA in all the pediatric cataracts? Anyone else having any opinion? Anthony? PA in all pediatric cataracts, irrespective of in the back, type of cataracts. What is your?
If it's in the bag, I will usually we don't do.
I also don't do it,
Yeah.
but in his experience, he's suggesting that.
Yeah.
I think we are not going to do
I
any.
think if you're doing if you're doing a vitrectomy and you're doing extracapsular extraction, I think there is a very little risk of pupillary block. So routine cases not at all required.
Okay.
And we haven't done it for 20 years, I guess. But uveitic cataract, yes. More the merrier. So, good morning. Thank you to the organizing committee and Dr. Supraja particularly for inviting me and accommodating my request for having the session on the Sunday. So only people who don't get complications are probably those who don't operate. Rest of us who are mortal human beings do get complications all the time. So complications can be divided into three groups, especially if you're talking about pediatric cataracts. There are intraoperative complications, postoperative, and late complications. So these are the most common intraoperative complications which you will observe. Um, so rexis extension is probably the most most distressing, as well as a little bit more common. And both the elastic nature of the capsule, intumescence of the lens, and of course experience of the surgeon are the factors where you, and this can happen both as well, anterior as well as a posterior capsulotomy. And as some of the speakers, Dr. Ramesh has mentioned it, it is something which anticipation and prevention is the best management. So if, as Dr. Jyoti was mentioning, if you see an intumescent lens, probably you should decompress first and then proceed with the, so that is where the role of anticipation and prevention comes in. But it is also helped by using a cohesive OVD, dyes like trypan blue, so that his visibility is better, and lens decompression. And if it does happen, all is not lost. Best is to keep a calm mind, and you can use the capsular flap and use use the scissors and all to still make it happen with in the bag. Implantation is possible, or at least a fairly secure sulcus implantation is definitely possible. And as Dr. Kavita was mentioning, microcapsular forceps and scissors are your best friends when you are to fashion some kind of a bag if you do have an extension. So this is a small video. This is me operating, okay? I'm not going to give a disclaimer, my fellow was operating and all. This is me. So you can see there is an intumescence, and my rexis is already extending. I do try to decompress. I should have probably gone ahead and decompressed, but before I can control it, it's already kind of gone away on the other side, despite taking all the care using a good OVD. But as you can see, it's just one radial extension, and you can use the scissors to cut the flap so that you can make it a kind of a round, regular opening which does not extend. And you can still do a PPC and put a lens in the bag away from the extension edges, and you will have still a good 270-degree or more than that cover over the IOL, and unlikely to get decentered or create a major problems. So it is possible to convert extended rexis into a fairly regular rexis. And you can see this is another traumatic case where the lens was already ruptured, and this is, I think, 15 years follow-up now. Lens is very securely inside the flaps, and you can see that visual axis is still clear despite some pigmentation on the lens. Now, PC rent can happen even if it's not anticipated, and sometimes you can have an extension of the posterior capsules, posterior capsulotomy, both. Myopic children as well as those with posterior capsular weakness. Sometimes in posterior lenticonus there may not be an obvious rent, but it's a very weak capsule, and you can have both extensions while doing PPC. And again here, rounding of the edges makes the rent safe to implant an IOL. And if not possible in the bag, you can definitely implant in the sulcus. So if you can see this video here, this is a myopic child, and I was not planning, he's around 10 years old, and I was not planning to do a PPC at all. And this is a little bit of an error of a overconfidence. As you can see, my movements while doing a PC polishing are a little jerky and not really smooth and peaceful. And there you had an unanticipated rent. So now you can see it's a fairly regular rent starting, but still keeping your head calm, you can still convert a PC rent into a PPC and do a fairly good anterior vitrectomy to make sure that there is no traction anywhere, and it is still possible to put the lens in the bag, or you can even look at pupil optic capture of the IOL in such situations. If you are not very sure, you can put a 3-piece IOL in the sulcus and do a pupillary capture, which is also a good technique to have. So here I was able to round it off into a fairly regular PPC. So I was able to put a lens in the bag in this situation. Now IOL dislocation in the vitreous cavity is a very unique situation only for the pediatric cataracts. I have had several times lens injected through the PPC into the vitreous cavity. And it can also happen if a PPC extends due to a tag which you did not realize. You can have, especially in younger children where bags are small, you can actually extend the PPC. Again, here cohesive OVD to inflate the bag and right technique of injecting the IOL preventive measures. And if lens is sinking, use a forceps and spatula that can be used to reposition the lens in the bag, or remove the lens and replace it with a sulcus fixated IOL. But important thing is to do a good vitrectomy even after you remove the IOL. Now, immediate postoperative complications, wound leak, iris prolapse, inflammation, infections, and IOP spikes. These are all fairly common. Of the three, if you are suturing, iris prolapse and wound leaks are not that common. I think almost everybody advocates, and I will not go over the importance of suturing in children. If I have never regretted anything in life, it is like suturing. I may have regretted not suturing, but I have never regretted suturing. So that goes without saying. Now, infection and inflammation, again, it's more in younger children and settings like trauma and uveitis. Children with torch infections related cataracts are also likely to have severe postoperative inflammation, and you should be prepared for that. For infection, if you have an LD block or is an endophthalmitis, is a risk for endophthalmitis. And initially, infection and inflammation both may appear indistinguishable in the initial phases, and both almost always need emergency attention. So this is our paper on endophthalmitis in children post-cataract surgery, and the lessons which learned from analyzing our data was that we have to watch for 48 to 72 hours. Most of the infections are likely to appear within 72 hours, and AC tap and culture are required in cases where there is vitritis and hypopyon. And better to treat an inflammation as an infection unless proved otherwise. Early vitrectomy got a fairly good visual outcome in our series. Late complications are, of course, visual axis opacification, secondary glaucoma, decentration of the lenses, and retinal detachments. VO incidence is 100% if you don't tackle posterior capsule, and can undo most of the benefit of the surgery within few weeks. Older children, you can do a YAG capsulotomy. In younger children, probably membranectomy is preferred, and may require a pars plana approach. And why I am saying is this is, if you look, this is a YAG capsulotomy under general anesthesia. It looks a little scary, if not. So probably surgery is better. We have done YAG capsulotomies like this, but so membranectomy is a probably better approach here. Now glaucoma. Glaucoma, sometimes this is a primary glaucoma and you are never going to miss it. But this is a cataract, post-cataract glaucoma where everything looks normal, and this is likely to be missed if you don't check the pressures really seriously. So again, asymptomatic unless too late. Incidence increases with the number of years of follow-up, and constant vigilance is required. Myopic shift and disc changes should be looked at, because sometimes these children, you may not have IOP checking in very young children, but please look at the myopic shift and disc changes which alert you to the glaucoma. Glaucomas are mostly open angle, and luckily, luckily they respond well to the medication, and AGM is usually the first line of management, and surgery is required as a last option. So this paper which we have done looked at our own data here, and we found that microcornea and younger age at the surgery were two really risk factors related to the glaucoma. Retinal detachment is rare but vision threatening, usually rhegmatogenous. Again, we found the risk factors to be myopia and intellectual disability in children. So these children probably need a more detailed fundus evaluation, if required US, and wide field imaging. Like in this patient, you can see this is likely to cause trouble in future, is very helpful. Thank you very much for the attention.
So, no, just to say that, yeah, the importance is follow-up, and like adults, once we give the glasses, it's the end, they come back, take it, and then they don't have to come. But in pediatric, depending on the age we've operated, follow-up is very important. Starts initially, immediately 1 week post-op, then 3 weeks, then 6 weeks, but thereafter it has to be 3 monthly. And each visit we have to get the pressure tested so that we avoid any complications, fundus checkup, look at the disc so that sometimes if the pressure is not being able to take because children may not be cooperative, you can at least look at the disc which is going into cupping and pick up a glaucoma. So follow-up will be there till the child is pretty old so that we don't miss any complications related to pediatric cataract surgery.
And the younger the age at which you have operated, the higher the risk of glaucoma. So if you operated at 4 weeks, the risk of glaucoma is much higher than if you have operated at 3 months or 4 months or so. So the smaller the child you've operated, the better, the more rigorous should be the follow-up for glaucoma.
Not to hesitate to examine them under short anesthesia, because that's the commonest thing. As an individual practitioner, we'll have a hesitation. The doubts on the parents' mind is a repeated anesthesia going to cause complication when they have systemic other complications also. That we'll have to highlight, and now it's a pretty well done procedure also. Very easy, comfortable for us.
Thank you so much. Any questions? We have just maybe 2 minutes. Thank you, all the speakers, wonderful talks and a group photo.
Speakers plus 3 or all debaters are here. The debaters big orbit.
It's a large hall with a nice audience. Can we ask all of you to come a little forward and occupy the front rows? Yes, so we can prevent you from running away, in fact.